Next, we're going to talk about benign biliary disease. We'll start with the calculus biliary diseases. There's a couple categories as we go through the presentation here. Calculus biliary disease, pigmented stones. So 20% of gallstones are pigmented. We're going to talk about the pigmented ones here. So first are the black. These tend to occur within the gallbladder itself. They're hemolytic or in cirrhotic patients. Next will be the brown ones. These are within the bile ducts. They tend to form within the bile ducts at least. More indicative of biliary dysmotility and bacterial infection, or more susceptible to bacterial infection. Why exactly these pigmented stones form? So these four predominant theories, or maybe coinciding theories. We'll talk about each one in kind. So first is the supersaturation of bile sent into the gallbladder. So that bile is actually sent into the gallbladder, and it's currently moving around, and so the solutes can kind of just keep twisting up inside the fluid, and as it's sent to the gallbladder, all of a sudden now it's encounters stasis, and so they just kind of settle out. Second would be concentration of bile within the gallbladder, because there's actually an absorption of water and sodium, well, mainly sodium and water following sodium through the wall of the gallbladder, which leaves behind the other salts, which do not have a carrier to come through the wall. Then there's crystal nucleation, which is essentially where glycoproteins and immunoglobulin essentially form a matrix that allows a crystallization of the salts within the bile. And then there's gallbladder dysmotility, which occurs in situations of prolonged fasting, which is mainly with TPN, long-term TPN patients, status post-vagotomy patients, and those who are on somatostatin analogs, particularly depot applications. Biliary colic is a distinct etiology of the pain, which is essentially where endogenous CCK induces gallbladder contraction against a lodged stone. So when you get this, this is the pain that our patient. What do we do about these patients that have biliary colic, suggestive of symptomatic cholelithiasis? Well, should we do a prophylactic cholecystectomy? The evidence shows that most gallstones are in fact asymptomatic, and in fact 20 to 30% of those who are affected now will have serious or significant symptoms within the next 20 years. Only 1% of those affected will have incur a complication without significant symptoms beforehand. And so the idea is that in this population, if something serious is going to happen, we're almost certain to have a warning of it beforehand and have an opportunity to do a cholecystectomy then. What are the exceptions to this, however? Who with biliary colic is worth actually doing a prophylactic cholecystectomy on? And those are those with a high rate of pigment stone formation, because those high pigment stone formers are going to have more bilious episodes throughout the course of their life than the average person with symptomatic cholelithiasis, and in situations where cholecystitis can prompt a crisis, so for example an immunocompromised patient. Another would be a person with a calcified gallbladder wall, and this is just a reminder to keep everybody engaged. That's a porcelain gallbladder, right? And someone who has large gallstones, and I'm not sure if it's common knowledge, but the cutoff for that is somebody that has a 2.5 centimeter gallstone or above. If you have a single 2.5 centimeter gallstone or above, you ought to have a prophylactic cholecystectomy. Also, if the patients have a long common channel, and that's where the pancreatic and cystic channels come together, you tend to have a much higher risk of having a choledocholithiasis. And then in those undergoing bariatric surgery, where the rapid weight loss causes essentially chaos to the biliary tree and biliary system, and it also makes it notably in a situation of a Roux-en-Y very difficult to do an ERCP. And then transplant recipients, because they're immunocompromised, they're very high risk of essentially having a significant event down the road that is gallbladder induced, and if they do have any sort of gallbladder issue, it's going to be serious, so we might as well take care of it now. Now there are some medical treatment options we rarely talk about. They have a very high failure rate, 20 to 50% recurrence, and that recurrence is within 10 years. So those will be oral bile salt therapies, contact dissolution, which is essentially a mechanism by which you just essentially modify the person's diet and medication regimen in a way to sort of start to dissolve the stones that are in there. And then the third is a extracorporeal lithotripsy, which is sort of a stone management via lithotripsy. It can be effective for a single stone that's 1/2 to 2 centimeters, but it's not largely, but evidence suggests that it's not very effective on anything smaller. So acute cholecystitis, when we encounter this, we rely upon these tests, and I wanted to sort of explain what these tests mean. And we understand, what their clinical significance, but I don't think we're necessarily as familiar with their sensitivity and specificities. That's what we're talking about here. So right upper quadrant pain will be tender to palpation in acute cholecystitis. The sensitivity is 58% and the specificity is 42%. Okay. Now a formal Murphy sign, the sensitivity is actually 48%, but the specificity is 79%. Okay. So a lot of people that have gallbladder disease without having a Murphy sign, but if they have it, probably do. The high likelihood they actually do have acute cholecystitis. Now imaging. Interestingly, if you get an acute abdominal series, obviously this is not what you normally get. You would see these on acute abdominal series when they're cholelithiasis, and again, not cholecystitis. This is why I put the asterisk here. This is specifically for acute cholelithiasis. But in the situation of that, if you see the stones, they almost certainly have gallbladder disease. So someone with right upper quadrant pain and cholelithiasis noted on a KUB, that's probably a patient who has gallbladder acute cholecystitis at least. If, however, the patient has, it's very obviously not a very good test to perform in people for the sole purpose of trying to evaluate whether or not they have acute cholecystitis or not. Moving along, a CT abdomen pelvis and a chest, because the reason I put the chest in there is, remember, the chest does overlap significantly down, and so oftentimes these patients will, a lot of chest breeds due to gallbladder, stones and whatnot. Sensitivity is 65%, specificity is 90% for acute cholecystitis. And a right upper quadrant ultrasound has a specificity of 95%. It's a very high sensitivity as well. MRI is high on both accounts, but remember that's kind of an overkill for this sort of, for just diagnosing your everyday acute cholecystitis. And then the HIDA scan is also very sensitive and specific in the case of acute cholecystitis. Now, normally we use it more or less as a negative thing to kind of rule out cholecystitis in a patient who seems benign, and that frankly this suggests that that's a fair utilization of that. Okay, so the radiology read may address stones, polyps, hepatic parenchymal disease, wall thickness, duct diameter, sludge, pericocystic fluid, and fat straining and cholesterolosis, which is cholesterol accumulations within mucosal macrophages. Now, of these, I think we're familiar with all of them, but the last one I want to give some images here. So this is that cholecystosis here, and here's some more, and they're very pretty pictures, and here's some more. All right, chronic cholecystitis, essentially repeated episodes of biliary colic, at least a fibrosis of the gallbladder neck and the cystic duct. They tend to get more severe, more frequent as they go along because of that development of fibrosis of the gallbladder neck. Only 50% actually endorses a fatty meal or some sort of association with fatty meals. Biliary colic is best identified as pain at the epigastrium and right upper quadrant pain. Pain radiates around to the scapula, but not through to the scapula. There's bloating, nausea, and vomiting as associated, and the pain tends to wax and wane. Note all may occur without actual stones, so if the patient doesn't actually have stones in their gallbladder, they may very legitimately have all these symptoms. Okay, perhaps it's just a sludge or something like that. Consider a trial of lifestyle and dietary modifications in these patients. Mild symptoms actually only have a 1 to 3% annual complication rate. And by complication in this sense, I mean just 1 to 3% issue with their gallbladder, a gallbladder requiring inpatient evaluation. Now, if they have severe symptoms, they actually have maybe 7 to 9, let's say 10% annual complication rate. So that's a bit more significant. You think, well, it's 10% this year, but the guy's only 40. We got a while to go, and it's almost certainly going to become a bigger issue as time goes on. Symptomatic cholecystitis itself is an indication for cholecystectomy. All right. That said, you need to document the chronicity of the pain and other symptoms, and you need to document the radiologic evidence of stones. And this is, one of our attendings, so we'll talk about billing a lot, likes to emphasize what do you need to document. This can be done to coordinate at an outpatient basis, but if you encounter So if you're trying to coordinate something like a chronic cholecystitis thing with an outpatient, the patient describes pain more than 24 hours or fever or leukocytosis or something triggering your gestalt otherwise, just slide on down to the OR. It's always better to act now than wait for a complication to occur. In the acute cholecystitis setting, there'll be biliary colic, so stone, sludge, box, cystic duct. And in the acute cholecystitis, there's the stone, which is sludge, blocked the cystic duct, as in biliary colic. The difference is this, that in biliary colic, it tends to be temporary and self-limiting, whereas acute cholecystitis, it really does not resolve spontaneously, okay? A lot of patients, if they have a resolving picture, they can really be treated more like a chronic cholecystitic picture. They do have tissue inflammation, which leads to wall edema, infection of stagnant bile, which is kind of a secondary process on top of us all. It's important to say it because the infection of the bile is not the primary issue. And then there's also subserosal hemorrhage that will occur, and that is it separates the tissue planes. It leads to more of a significant edematous collection and ultimately towards emphysema. Unresolved cystic duct obstruction leads to infection of the bile, leads to wall ischemia as well, which leads to necrosis and gangrene and emphysema. There's interval cholecystectomy, which is offered to patients who have a picture that essentially is a relapsing picture, or a picture that is easily and readily addressed in the ED or resolves within the ED. We can give them an interval cholecystectomy. These patients, if we bring them in with, we normally feed them, give them IV fluids, IV antibiotics. If you do it, it's interesting. If you do it with within the first week or at the 6th week, so in the first week or in that 6th week, there's actually comparable laparoscopic outcomes. Now, if you do the 2 through 5, you actually get worse outcomes than if you do it either at the 1st or 6th. And that's actually a meta-analysis confirmed trend. It's not just a single study. All right, medical management fails in 20% of these patients. So again, we're talking about the first thing we do for these cholecystectomy patients is, well, medical management, right? And see how things go, wait till things cool off. Well, it fails in 20% of patients. Now, if there's a difficult gallbladder, you're encouraged to convert to open. You'll see most of our staff are fairly willing to do that. You can always do a partial cholecystectomy where you leave part behind. I'm sure someone will do an M&M on it, but essentially you decide what you're going to leave behind and you sort of structure your dissection around that. A lot of times you'll leave kind of that posterior plate. Sometimes you'll leave part of the infundibulum, but you do have to be concerned about stump cholecystitis like we're encountering in M&M this week. You can also place in these patients a percutaneous cholecystostomy tube. Generally, it buys you about 36 months a time. And then you can always do a gastrograph and flush to determine the patency of the duct and whether or not it's worth pulling or worth doing scheduling that person for a gallbladder when you take it out. Next, we'll transition to choledocholithiasis. This is when a stone lodges within the gallbladder duct with the ampulla, classified as primary or secondary. And Dr. Chambers has a great lecture on this, so I'll just kind of breeze through it. The primary choledocholithiases are those that form organically in the common bile duct. Normally, we kind of say it has to be at least 2 years. Sometimes, some people use a 1-year cutoff, but 2 years status post cholecystectomy to say that, hey, this wasn't dislodged during the cholecystectomy itself. Normally, these are brown stones. If you remember way back to the beginning of this lecture, we talked about brown stones are more common in the ducts and more common in Asians, and they're a very high infection risk. One, because they're in the duct, and number 2, they're adjacent to any refluxing bile or whatnot that may come up to the papilla. And third, they're actually intrinsically, the brown stones are just simply more prone to infection because of some of the structural issues as well. Now, bacteria secrete enzymes like glucuronidases, which hydrolyze the bilirubin and glucuronide. So what happens there is that the bilirubin precipitates. And when it precipitates, bilirubin binds up cholesterol. That's kind of what it does. And so as it binds up cholesterol, you get stones. That's how the primary stones work. Now, secondary stones occur less than 2 years from a live chole. Anything that occurs less than 2 years, we call it a primary stone or secondary stone. Majority of all common bile duct in the U.S. or common bile duct stones in the U.S. are secondary stones. And actually, at least they suggest that 1 out of every 10 lap choles will leave a stone behind. One, 1 to 2% are clinically relevant of these. Um, Most of those stones that are left behind will just pass on their own. Now, symptoms are biliary colic, jaundice, scleral icterus, dark urine, light-colored stools, diarrhea, elevated direct relative to total bilirubin, elevated LFTs, and a common bile duct dilated above 8 millimeters. Now, diagnosis is if you have a low suspicion, send them to an MRCP. If you have a high suspicion, you ought to proceed directly to ERCP. Though I'm sure several of you are shaking your head, that's just not how it works here. And so we send everyone to MRCP so that the GI guys will do an ERCP. Treatment is actually the ERCP, which is the point of taking them when you have a high risk or high suspicion. But ERCP or a lap common bile duct exploration or open common bile duct exploration. So an ERCP is 75% successful on their first attempt and 90% with subsequent attempts up to 3. There's 8% complication risk, which occurs almost exclusively in patients that have a sphincterotomy and a sweep. Now, if you're going to do an ERCP without a sphincterotomy and a sweep, however, you're essentially doing a useless one. The point is, this is it's an acceptable complication rate. If cholecystectomy, however, is not performed after an ERCP, so a patient goes to ERCP and they do not come back for follow-up, among all patients, 50% will reobstruct, but among those over 70, 15% will reobstruct. So it's interesting that actually old people really do not reobstruct nearly as much as younger people do. It's a little bit of an inverse of what you would expect, largely due to the higher caliber common bile duct. Now you can perform a laparoscopic common bile duct exploration. This requires a facile surgeon, as is repeated over and over again. Essentially, you're seeing somebody who knows what they're doing. All right. You can do a transcystic approach, where you approach via the cystic duct and you get in, or if you encounter a stone that's too big, such as a small friable duct, or 8 or more stones, or a very large stone over 1 centimeter, then what you do is you essentially go down, incise into the common bile duct itself and retrieve the stone. Now, unfortunately, the morbidity of that common bile duct exploration is actually fairly high, 4 to 12%. Mortality is 1 to 2%, something like that. But if you're unable to clear the ampullary stone, then you've really got 2 options. One is a choledochoduodenostomy, and the second is a choledochojejunostomy. Now, the choledochoduodenostomy, where you're hooking on the biliary structures onto the duodenum, the benefit is you can still do an ERCP because the anatomy is still very much the same as it was before. But the problem is that the patient risks a significant issue, risks significant sump syndrome concerns. And sump syndrome is essentially where you have the duct is the biliary tree is unable to drain properly, and so it causes backup and pain, things like that, and obstructive symptoms. Now, the choledochojejunostomy, you have to do a Roux-en-Y. You bring it up, it drains just fine. It's anatomic, like lie is perfect, all that stuff. The problem is that you can't ERCP these patients afterwards. Now, next up would be gallstone pancreatitis. We'll sort of switch gears to that now. If you do have pancreatitis of unknown cause, get an ultrasound because it may be gallstone pancreatitis. If it is the proximate cause, pancreatitis is fortunately self-limited. So pancreatitis, as we know, is a very variable course and has a lot of complications and very unpredictable. But in this case, you can generally say that if it's a stone-induced cholelithiasis-induced pancreatitis, then the patient's outcome is pretty promising. There's ERCP indications to remove the stone. So a lot of time, if you got pancreatitis and you send them down, you want to see if they got a stone. Sometimes MRCP, I guess in theory, sometimes you can send them directly to ERCP and they would investigate. The patient gets a cholecystectomy, once recuperates. So this will happen again and again. Now, if the patient has biliary dyskinesia, now this is a difficult, a little bit more of a difficult diagnosis. This person presents with biliary colic, but no stones on their ultrasound. So you rule out other etiologies for the pain with a CT and EGD. Now, this is where you order a HIDA. You order a HIDA and you see, well, what the heck's going on there? And if the ejection fraction is less than 33% at 20 minutes, it confirms dyskinesia, okay? Um, cholecystectomy resolves pain in about 85% of patients. And then if it doesn't, you do an ERCP and a sphincterotomy, and that will resolve the pain in the remainder of the patients. Now, sphincter of Oddi dysfunction, this is there's some question about whether this is a real deal or not, but essentially this is, we hear a lot in the context of narcotics, contracting that sphincter of Oddi, cause pain, elevated LFTs, and pancreatitis, common bile duct greater than 12 millimeters. So that's, if you find a common bile duct greater than 12 millimeters and elevated LFTs and such, and if you still see no stone, you still have a high index of suspicion that this may be a sphincter of Oddi dysfunction instead. Sphincterotomy results in pain in a majority of patients. Now, if you do happen to have an iatrogenic bile duct injury during one of these procedures, we're just moving along to the chapter. There's another kind of, this is kind of the next section is bile duct injuries. You got to control that infection. So IV antibiotics and perk drain. Of course, you remove everything you can, but then you do IV antibiotics and a perk drain. You delineate the anatomy, MRCP. You can do a percutaneous cholangiogram or ERCP. Normally MRCP. You control the leak with either put a stent across it or just percutaneous drainage. Then you restore the anatomy, so you can either do what we talked about earlier, like a hepatic or jejunostomy, or you do, whatever you can do to essentially reattach the liver biliary structures to a reasonably well draining, a portion of the alimentary canal. And then, all right, so moving along to spilled stones, it's kind of related to that in a way, in that spilled stones are essentially when the gallbladder perforates during the coli. We normally think of these in kind of, I think flippantly, but they're more significant than perhaps we occasionally recognize. Risk factors are obviously cholecystitis because it's a friable gallbladder, pigmented stones because there tends to be more and they tend to be more difficult to remove, and you can't see them through the wall of the gallbladder. If there's more than 15 stones, that's a huge risk factor. And sadly, but I think understandably, if there's a surgical resident performing the case, there's a higher likelihood of risk of letting the bag loose, I'd say. These things, although we think of them pretty benignly, they can cause chronic abscesses, especially in Morrison's pouch. They can cause small bowel obstructions due to recurrent adhesions that are formed. They can cause fistulas as well, and if they erode all the way through. So prevention is obviously the key here. You just want to find them, lots of irrigation, and make sure they get post-op antibiotics. Next will be a situation to talk about is gallstone ileus. This was, I think this was my first mock orals. I got this is my first problem on my first mock orals by Mark Miller. So this is a gallbladder when the gallbladder fistulizes to the duodenum. This is normally from a long-term inflammation. It sort of fistulizes right on over. Gallstone passes through it, and then that gallstone mechanically blocks the small bowel, notably not at the ileocecal valve. That's what everyone says, but that's not it. It's actually at the taper preceding the ileocecal valve, okay? Tends to occur more likely in elderly and necrotic gallbladder patients. I'm sorry, elderly and patients who are more likely to have necrotic gallbladders. And the CT will show pneumobilia and small bowel obstruction with air fluid levels. The way you treat this is to go, it's generally open, but I guess some may do it laparoscopically, but if you're going to do it open, you go down, you essentially find your stone or your blockage, do a anti-mesenteric incision, longitudinal incision. You check out essentially the gallstone and determine, retrieve it. Hopefully it's a gallstone. If it's a malignancy or something else, well, you get your answer elsewhere. Take it out. Run the rest of the bowel. About 10% of the time, there'll be additional stones that are proximal. If they are, then you run them down to the longitudinal slit you just made because you have not sewn it shut yet. So then once you finish running the bowel, that's when you go back and you close the longitudinal incision transversely, okay? If the patient's healthy, you wait a day or two and then you do a chole. If the patient's comorbid, then you repair the neurotomy and you do it later or maybe never. You can actually leave that gallbladder communicating fistula in situ in many elderly patients. It was a reminder to kind of put this all together. What's normal? Cholecystitis, you get red upper quadrant pain, you get a Murphy sign, mild elevation, all that stuff, leukocytosis, and a fever. Choledocholithiasis, you get red upper quadrant pain, you get a Murphy, you get elevated direct bilirubin over total bilirubin, which is a pretty, if you once you see that ratio going up, and direct bilirubin, direct bilirubin is composing more and more of a significant portion of the total bilirubin, then you suggestive of an occlusion, like a choledocholis. You do get elevated liver function tests, and you get jaundice and scleroicterus. So these don't look all that much different from each other. But here's the important part: in neither of these cases, in neither of these simple cases, do you get overt sepsis, rigors, or hypotension. And I say that because if you do have those, you may recognize those three things together are Charcot's triad. Okay, so jaundice, red upper quadrant pain, and rigors together. You get Charcot's triad. Raynaud's pentad is when you add hypotension and alter mental status. Now, why is that important? Well, it's important because if you've got jaundice, red upper quadrant, pain and fever, then you've got ascending or a very high chance of having ascending cholangitis, and it's a very critical concern for the patient. If they have Raynaud's pentad, they're a very unstable and very, very concerning patient that needs GI to come in. Okay. Now, notably, as far as Charcot's triad is concerned, all three criteria are only seen in less than 50% of patients. So oftentimes, and jaundice is the most variable and most not included. So oftentimes, right upper quadrant pain and fever / rigors, that's all, which is a real severely shaking fever. That when you get right upper quadrant pain and rigors, that in alone may be oftentimes all you get to suggest triad. There's two absolute factors in this ascending cholangitis. One is bacteria so you're going to have Klebsiella, E. coli, all that stuff that we know that lives in the enteric tract just happens to be now living up in the biliary tract. And you'll have to have an obstruction to the flow forward. So you're not going to have ascending cholangitis in the absence of that. Okay. So right upper quadrant ultrasound will reveal a dilated biliary tree. You can do cholangiography. You can remove this, and then you got to remove the stones. So either way, you got to image it. Whether or not you need cholangiography or not is a personal issue or a personal preference. But you got to remove the stones, and so you do ERCP or endoscopy for that. If you endoscopically remove the stones, you essentially ERCP or laparoscopy. ERCP is you're going to do a sphincterotomy and a sweep. If you're going to do it laparoscopically, then you remove the stone and make sure you've got a clear cholangiogram afterwards. Then you'll there's other options to temporize, which will decompress the biliary tree. You can do ERCP can do that, or percutaneous transhepatic cholangiogram can do that, or endoscopy can do that as well via sliding essentially a tube alongside and through the sphincter. And again, you can also do it laparoscopically, but I didn't put that in there. But obviously, you can decompress anything laparoscopically. So if there's unstable, the patient gets a T-tube. That's and they're deferred. We talk more about T-tubes later in Dr. Chambers' lecture. All right, recurrent pyogenic cholangitis. Now this is a different, distinct thing from what we just talked about, ascending cholangitis. Recurrent pyogenic cholangitis occurs primarily with these two organisms, Clonorchis sinensis and Ascaris lumbricoides. Both of them secrete an enzyme, the glucuronidase, from earlier. If you remember, that actually breaks up that bilirubin-glucuronide bond. And what it does is it causes the bilirubin to essentially be free and the glucuronide to do the same. You get repeat stones and repeat bouts of cholangitis, and eventually those work their way up the biliary tree until you get abscesses and cirrhosis. You do antibiotics now, then you go to the OR. So what's the point of the OR? Well, you're going to remove the stones, you need to bypass strictures and evaluate for strictures, and you need to improve biliary drainage. And that may very well mean making something like a hepatocoagulopathy or something like that that allows you to drain more effectively. There's a high risk of cholangiocarcinoma with patients that have recurrent pyogenic cholangitis. Because of that, both Clonorchis and Ascaris tend to be a lot of metaplasia at their locations, and that essentially the metaplasia eventually turns to dysplasia and then to potential malignancy. So there, if you take this patient to the OR, they're actually uh, great outcomes. Okay, so you get great outcomes as in it's almost 100% cured if you take them to the operating room. But the problem is that you know if there's not a cholangiocarcinoma there, then it was essentially you kind of did overkill. And so that's kind of the idea is that you want to go to the operating room if you really need to, if there's an obstruction that's refractory to ERCP or something like that. But for the most part, you ought not go there. Okay. All done with this calculus biliary disease view. So we're kind of done with that. We're going to do a brief kind of walk into the acalculus biliary diseases. So biliary dyskinesia, talked about before. There's kind of a little bit biliary colic, no stones on ultrasound. Rule out other etiologies for pain with the CT and the EGD, and then you just do the height of it, the CCK. Ejection fraction less than 30%, 20 minutes, confirms dyskinesia. Okay. Cholecystectomy resolves pain most of the time. Centrotomy does the rest. This is distinct from acalculous cholecystitis. Okay, acalculous cholecystitis it looks just like acute cholecystitis, but it's a more fulminant, more refractory presentation. The etiology is kind of elusive. It's not stones associated. And it happens, and we almost always see this in our ICU consults. Elderly, infirm ICU, burn, trauma, TPN, diabetic patients, TPN because it's long-term, no oral intake, diabetes, and immunocompromised patients. You can get a reticular ultrasound or a HIDA. The HIDA do have a significant false positive rate, though, in this particular condition. Not normally, but in this particular acalculous cholecystitis, they do. Treatment is an open chole versus a perc chole. Most people don't do laparoscopic cholecystectomy because these patients are too ill to begin with, which is why they got into this situation to begin with. Next important kind of miscellaneous one to talk about is a condition to talk about is a primary sclerosing cholangitis. This is inflammation and scar at the intra and extrahepatic biliary tree normally, although it can be one or the other. It advances to cholecystasis, so eventually it obstructs completely. It's autoimmune in nature, associated with Rydell's, as well as ulcerative colitis. Notably, there's no effects, so even if you do a proctocolectomy on a patient and they have no evidence of biliary disease, years later, they still remain at a much higher risk of having primary sclerosing cholangitis. The P-ANCA protein is elevated up to 80% of folks. There's fatigue, pruritus, and jaundice. High risk of a conversion to cholangiocarcinoma. This kind of makes sense that every time you've got this, it seems like the biliary tree more than almost anywhere is very responsive to essentially ongoing inflammatory processes, whether it be by Clonorchis or whether it be, in this case, by repeated bouts of primary sclerosing cholangitis. Either way, it is a great conversion over to metaplastic tissue or malignant tissue there. Diagnosis with the ERCP, and you'll see like this phenomenon called the beating or the chain of lakes. And so I've got a couple illustrations here coming. And then there's you can do biliary reconstruction, or just say forget it, we're getting a liver transplant. The question is, will it reoccur in a liver transplant patient? And the evidence suggests it will indeed reoccur there, even though it's now a different liver in a different patient. Very interesting. So this is that beating we're talking about right in the middle of the page. You can kind of see on the illustration there's a little beating there, and then on this ultrasound image you can on the CT image you can see the same, or ERCP image you can see the same. Here's another image, ERCP image of the biliary tree as it's doing its sort of small strictures and dilated areas, beads. Here's another example. So now as we kind of round things off, we're going to get into the choledochal biliary cysts. These are rare, occur in Asian females. Interestingly, 90% of these patients also have anomalous pancreaticobiliary junction, so meaning that their ducts come together too early, so the pancreatic and cystic ducts come together too early. We'll say the pancreatic biliary channels come together too early. There's higher pressure on the pancreatic one, and so it actually refluxes its pancreatic enzymes and juices up into the biliary tree. This causes chronic irritation and cystic degeneration. So you get a CT and then an MRCP. So CT is kind of diagnostic, and MRCP is better characterizing of it. Just like we talked about before, though, that constant irritation of the pancreatitis, or the pancreatic enzymes refluxing up, unfortunately results in a conversion to cholangiocarcinoma in 30% of the patients. Interestingly, including way up, there's equal proportion, even way up in the liver, where those you'd think those would refluxes, they never refluxes that high, but apparently it must. In this case, you resect the cyst. That's really the way to address it. Okay? The reason primarily being that you don't want that 30-40% conversion, or 10 to 30% conversion rate to cholangiocarcinoma. There's lots of ways to reconstruct it, but this is an example of some of those. So we can just kind of see how they'd be a difficult challenge to put back together. Just another example here. Caroli disease is again rare in Asians. 7% of the patients with Caroli disease advance to cholangiocarcinoma. There's two variants. There's a focal variant, which is where it's in a single lobe, but it's severely involved in a single lobe of tissue, of liver rather. It's autorecessive. There's polycystic kidney disease is a close association. There's this other kind of variant, which is a simple variant, which is essentially you get signs and symptoms everywhere in the liver without any kind of focal aspect to it. Autosomal dominant in nature, so this one is inherited. The other one is also inherited, autosomal recessive. This one's autosomal dominant. Also associated with polycystic kidney disease. But interestingly, that also has portal hypotension or hypertension. It also has hepatic fibrosis. So these patients are much more severely involved in their liver, and as a result of that, they've got that portal hypertension and the backup of the congestion of fluid. Finally, to round things out, we'll just talk briefly about other things you might see on like ultrasound. For example, gallbladder polyps are very common. We kind of classify them into pseudotumors and adenomas. So pseudotumors are cholesterol-like or cholesterol derivatives, tend to be less than a centimeter. There's lots of them all over. We kind of saw those earlier, actually. We saw a number of images of those. So those would certainly not be an indication in themselves. Let's say an open gallbladder or something. Then there's adenomyomatosis, which are these sessile kind of microcysts. They tend to be large, but only one of them, all right, or maybe two of them. There's not significant involvement of the wall or of the gallbladder itself at all. They rarely involve the neck and are rarely occlusive. Then there's these adenomas, and these are benign, so not adenocarcinoma. It's difficult to distinguish whether adenomas or not because that invasion, that depth of invasion, is a primary issue, and it's the primary issue. Generally, in these cases, you favor an open chole to reduce the risk of perforation and seeding, just in case it is indeed an adenocarcinoma or malignant in nature, or there's something else afoot. You can excise them with a thin rim if they're very small, but it's okay actually to observe them. If they're under 10 millimeters, under a centimeter, you're actually okay to just observe them, especially if they have low-risk features on ultrasound, such as their venous flow and whatnot. That wraps the end of our long and somewhat tedious biliary chapter. I know most of the stuff's familiar, but perhaps I augmented a little bit of knowledge otherwise. We'll catch you on the next one to discuss more at Chief Lecture.